hopefully you brought some of those cases that were your most favorite, because I know these are like the most dreaded cases typically in EMS. It's like, oh my gosh, I don't want to deliver a baby. So we were just talking about this, Mark and I, and it's like, nobody wants to do it, but usually they deliver themselves, but sometimes they don't. So hopefully we'll get some good pointers on that. So anyway.
How do you switch over to the presentation?
Oh, that's not a me question. All right, so I'm going to turn the time over to them. Thank you for coming.
Yeah.
So I'm just curious, how many of you guys have actually delivered a baby out in the field? So, a decent, yeah, so it definitely happens. And if you guys also were talking, just kind of share your experience.
Oh, we're there, cool. Like Dr. Grace was saying, so I'm Dr. John, this is Dr. John. I'm family medicine and hated it. So I wanted to be in the hospital and wanted to deliver babies. Those are the two things that I loved, and they don't go together very well. So I ended up in the hospital, and Jalee is an OB-GYN. She's delivered a couple more babies than me, but
Just a couple.
So I titled this, "Oh shit, they're pregnant," because I feel like that this is one of those scenarios in medicine that if you don't know it, because you don't do it all that often, if you don't know it very well, then it's like, it seems kind of like this taboo, scary thing. Most doctors who don't deal with babies very much or deal with pregnancy very much want nothing to do with it, want to stay as far away from it as possible. Maybe some of you guys feel the same way. And it can be scary, it really can. I don't know which button to click here, but I'm going to try that one. No, that's not it. That's not it.
It might be me.
That's it. Yeah, that's it. Maybe, no? Oh no, that was you. I have a, yeah, show me.
It was working for 2 seconds ago.
Oh, maybe it just takes a minute.
It's
Okay.
just 2 minutes.
Okay. All right, so real quick introduction who we are. We are not the proud owners of Dr. John's. When Jalee's not from here, so she had no idea that these existed. And we weren't married, and we were on our way to getting married. And I said, hey, by the way, when you move to Utah, you need to know that, and you're an OB-GYN, you're going to hear a lot about this. And she really hasn't. I don't really hear it all that much.
No, I wish I could get stock.
I know, I was thinking we'd get royalties when we came to Utah, but we don't. So this is who we actually are. This is our boy and our girl. We have a third one on the way, so that's fun. So I'm from here. I grew up here, just up on the hill there. I went to Weber for undergrad. I went to Virginia for medical school. I did my residency in Pocatello, Idaho. While I was in residency, I did an advanced surgical obstetrical track, and then I did some wilderness medicine. I was in the Army for a bit as well, and then I currently work at Davis. And then Jalee's an OB-GYN, she's from Nebraska. She went to Marion University for her undergrad and medical school, did residency in New Jersey, and works at Tanner Clinic, where she delivers at both Davis and IHC Layton. So you might be wondering why am I here when she's the brains, obviously, of this bunch. And really, my job here, I have a little bit more EMS experience, not like you guys by any means, but I did wilderness medicine. I did search and rescue up in Idaho, and then in the military, I was a platoon leader for a bunch of medics here in Utah. That was forever ago. So I kind of have a taste of what you guys do. Not that I've actually done it by any means, but
And I know too much where I can get into the nitty gritty.
And Jalee knows too much.
You can be the translator for.
Yeah. So I'm more or less just a translator for what you really need to know, what you really need to take home. I'm kind of the dumb medicine. She's more of the specialty medicine, obviously. If you guys have any questions, want to share an experience, have a comment, feel free to just jump in. All right, obstetrical emergencies, objectives, why OB emergencies matter. They're not very often. They don't come very often. How you said so? Some of you have delivered. How many of you guys have gotten an OB call ever? Okay, so pretty much everyone. All right.
You're going a lot of miscarriages.
Okay. It's very high stress. I mean, you're meeting these people, and it could be the very best day of their lives. It could also be the very worst day of their lives. So that can be very stressful. Stressful for them, stressful for you. Very high stakes. You have two patients that you're dealing with. One of them you can see, the other one you can't see. And if anything were to go wrong, it can be a nightmare. And rapid decisions matter. I think in most cases, you're going to be transporting the patient to the hospital. Again, like I said, you have one patient that you can see, you can assess, but even if they look totally fine, you can't see the one that's on the inside. And so because of that, I think that most of the time, if not all the time, you're probably going to want to take them to the hospital to get the one on the inside looked at. Oh, by the way, I took all this from your protocol. Every single thing that's in these slides and stuff is from your guys' protocol. I didn't want to add too much or take away too much, so I just kind of followed that as my guideline. Your priorities, so obviously you get on site, you do a rapid assessment. Again, time really matters in this instance, so if there is time, by all means, get them in the ambulance, get them to the hospital. If there's no time, and you pretty much know if there's no time because there's a baby coming out, then you got to do what you got to do. But the faster you can make that decision, the better it's going to be for everybody. So you determine an imminent delivery versus transport, and then assist delivery if unavoidable, and recognize complications early. When you first show up, you're going to do your initial assessment, you're going to do your focus history and physical. 95% of that is just looking at the patient. I think you guys have probably come to the same conclusion that I have. You can walk into a patient's room and have 95% of the information you need without ever even touching the patient. Not that you shouldn't touch the patient, obviously, but you know pretty quickly whether, where we're at, if this is like a oh shit situation or a okay, maybe we can take a minute here and see what's really going on. Don't perform a pelvic exam. Not that you shouldn't look though. It is important to look down there, make sure you don't see a head coming out. Moms don't always know if that's the case.
Or bleeding.
Bleeding as well. Yeah, but don't be sticking your fingers in the vagina if you don't, or you're not supposed to be doing that. Cardiac monitoring, pulse ox, and then your end tidal CO2. I don't know how important that is for Jalee, but
I don't know what it is.
but it's
I don't do that.
but it's in your protocol. So, all right. So the questions you need to be asking, and these are really the thing that I love about OB. The reason why I wanted to go into OB so much. I'm not that smart of an individual, as you've already probably picked up. The thing I love about OB is that it's very tactile. It's gross medicine, not just disgusting, but it's also like, it's gross as in, you don't need to know biochemistry. You don't need to know the chemical reactions and the pathophysiology and the pharmacology of everything that's happening. I think OB is the most tactile, physical medicine that exists. It all makes sense. You have a baby inside, that baby's doing well, that baby's not doing well, that baby needs to stay in, that baby needs to come out. And so when it comes to all the different maneuvers and all the different treatments that you're going to be doing, they're all very physical, which means they're very intuitive. You don't really need to know the Krebs cycle and the different pathways that occur to know exactly what you need to do next. It kind of is self-evident as you're going through the process of delivering a baby. And so that's one of the things that I love most about it. So all these questions are ones that you'd probably think of naturally. Even if I just said, hey, what questions do you want to ask a pregnant lady? These are probably some of the questions that you want to know. Intuitively, without needing to sit down and memorize it and come up with a mnemonic and none of that stuff. It's really basic, intuitive. So, how many weeks pregnant? Contraction frequency, is their water broken? Okay, if you ask a pregnant lady if her water's broken, what does that tell you? If she says, yes, my water's broken, does that mean her water's broken? Honestly, I love that. That was awesome because half of you said no, half of you said yes. That's exactly the right answer. It doesn't, who knows? It could not. The whole water broken question is really, if there is a giant puddle that doesn't smell like urine, yes, the water is broken. But I would say 50% of women who come into the hospital and say that their water's broken their water's not broken. And you'll get a good chunk of women who come in and they're like, I have a little leakage, and I'm thinking, her water's probably not broken, and it is broken. So you can't really know. And if you have a huge puddle between her legs, yeah, her water's probably broken. If you have a little leakage, could go either way, really. If you see nothing, she also could be broken. So you really can't know 100% unless there's a giant puddle that doesn't smell like urine. But outside of that, it's really hard to know if her water's broken or not. The urge to push, you're going to see that. She's going to be diaphoretic, she's going to be tachypnic, she's going to be feeling it, and she's going to be super uncomfortable. She's going to have an urge to push. And as the brain is this phenomenal, amazing thing, when they have the urge to push, there's nothing you're going to do to stop that. You can say, close your legs, don't push, don't push, don't push. They're gonna push. It's just gonna happen. So, previous births, why is that important? I love all that. Yep, complications. How fast is the baby gonna come? If they've had vaginal deliveries before, then the deliveries that happen afterwards usually come a lot faster. If they've had complications in previous deliveries or previous pregnancies, that's really important to know. And then, of course, complications during pregnancy as well. Again, the big question that you're asking yourself, what am I doing? Am I doing it right here, right now, or am I transporting them to the hospital? Any questions with any of this? Pretty basic. You guys have to participate a little bit. It's too early to just listen to me for however long.
So one of the things as he's figuring that out, that I like to, like he said, you can tell, people have babies in Africa, in fields, all the time, for centuries and millennia, so that's why I say my job is a little bit of a moot point of I try to make it more comfortable, and if we can make it safer, for sure, but you don't actually have to do a whole lot when it comes to the delivery portion, ideally. And so you definitely can tell when, for me, when a patient's being rolled down the hallway, if there's a panty dropper, as we call them, as the baby is coming out, or the wheelchair catches it, or you guys catch it. And so as they're kind of like screaming and freaking out, as part of these signs of delivery happening, like right now, they will be, as he said, unable to not push. The water breaking thing does only slightly, I totally agree with him, but there is a little bit of, if a mom thinks that her water broke, like that baby could really come at any second. If the mom's like, no, I have not had any leakage, then you at least know that the water has to break before the baby comes out. So you at least have that little cushion of like, well, the baby's not coming out yet because the water's still intact, so. Yeah.
All right. So signs of imminent delivery, crowning, obviously, that's why you're not going to do a pelvic exam, but you do need to look. Crowning, bulging perineum, a strong urge to push, as we said, contractions less than 2 minutes apart. Again, this is all very intuitive, right? It all kind of makes sense. I don't think any of these would surprise any of you. I don't think you really even need to go to school to understand this. Like, this is very obvious stuff.
And if the patient's like, I want to get to the hospital, like, get me to the hospital, then you pretty much have time to transport them. Versus if the patient's like, this baby's coming out now, then
Yeah.
7 out of 10 times the baby's coming out now.
Yeah. Which leads me to this. So I can't tell you how many patients I've seen, I've had. I've done a few hundred deliveries at this point, and how many patients will show up like this and they're perfectly fine. I mean, you guys see it all the time, I'm sure, in other aspects of medicine, that they appear like they are dying, and then you're like, you are fine, stop it. We've been here 6 times already, And so it happens all the time. The mom will come in, and I've literally had her stand there and go, I'm having a baby, and she's not having a baby. Or she'll say, my water's broke, and her water's not broken. Or the amount of times that they're saying, I'm having a contraction right now. If they're saying that, they're not having a contraction right now. Because when you have a contraction, for those who know, when you have a contraction, you're not saying anything. You're hurting, and you can't breathe, and you can't speak.
You'll scream. You'll scream.
So, what it really looks like when someone's having a baby is this. If you see this face, this is probably someone who is having a baby. This not so much. All right. So active labor, no imminent delivery. Who can tell me what active labor is? What does that mean?
Like consistent contractions.
Okay, dilating. Dilation's an important part. Contractions are an important part. So can anyone tell me, so this is one of the, I mean, active labor, I think all of us know it means that she's actively laboring. She's going to have a baby soon. But there is a criteria for it. Does anyone know what criteria is? It's 6 centimeters dilation. Now again, you guys aren't doing pelvic exams, so there's no way you could actually know that. But you could know it, or maybe know a little bit of it, which is through your contractions. Regular contractions, you know, I think in the old days they said 5 minutes apart. Your protocol says 2 minutes apart. But that's if they're actively crowning, I guess. But
Yeah, I don't know the 2 minutes. I have a lot of people deliver
yeah,
not at the 2 minute mark,
Yeah.
like 5 minutes.
Yeah.
10 minutes, I'm like, it's good. You at least, you know, can drive 20 minutes and get 2 contractions out over there and make it in time, but 5.
So, but there, but it needs to be both of those things. Very often, you'll have someone who is contracting regularly, but they're not dilated past a 6, and so that's not actually considered active labor. And then you have others who are dilated past a 6, but not contracting regularly, and so that's not active labor either. Again, there's really no way for you guys to know that unless you do a pelvic exam, which you can't do. So I guess what I'm saying is, I don't love this term, active labor, because you can't really know if they're in active labor or not. But if you're gonna guess that they are in active labor, then it's pretty basic. It's just supportive care, oxygen if needed, the left lateral positioning, transport to closest appropriate facility. Really not a whole lot to do there. When everything goes to plan, that happens often, right? So you do your initial assessment, you decide, hey, we're gonna have an imminent delivery. You have a normal delivery. Now, for those of you who haven't delivered a baby, we'll kind of go through some of these steps a little bit. So you want to support the baby's head. So as the baby's head is crowning, you're going to put a little tiny bit of pressure on that baby's head as it's coming out. You're just kind of supporting it. You kind of put your hand on it. When the babies typically come out with their head going perpendicular to the ground, or their head is vertical. Sunny side up.
You don't want sunny side up.
You don't want
Sunny side up is hard.
But their face is going to be either pointed up or going to be pointed down, typically. The second that head comes out and past the vagina, it's going to rotate. It's going to rotate either to the left or to the right. You don't know, you can't know. So the second that baby's head pops out, it's going to naturally rotate. At that point, you're going to put one hand on bottom, one hand on top, and just hold the baby's head right there. Now, the mom's going natural, which means that she's going to want to push. Okay, so you don't have to do a whole lot. Mom's going to do most of the work for you. And so, like I said, you're going to allow that head to rotate naturally, and then you're just going to hold the head while mom kind of pushes baby out. And then don't drop the baby. Okay. The second the shoulders come out, it happens real quick. It can take a solid, 10, 15 minutes to get that stinking head out of there and the shoulders out. And then it takes a whole whopping 2 seconds to get the rest of the body out. Okay, so the second those shoulders come through, you deliver the shoulders, I like that it says that, deliver shoulders one at a time, so they don't both come popping out. Usually what happens is that if you put I'm gonna say this carefully. Gently, if you put a little bit of downward pressure, you'll get that anterior shoulder to pop out, and then after that, the posterior shoulder pops out, you have a baby in your hands. It happens really quick. Don't drop the baby. Okay, never pull on the baby. That's fine. We don't need to go into that. But anything else there that you can think of?
For me, the biggest thing, and when we have our EMT students come to the hospital and deliver with us at Davis, like my big thing is with a patient going without an epidural, getting them to like open up their legs, because a lot of times they're screaming and they're pinching and they say, I can't do this, like I don't want to do this, like the baby's coming out, but and you're like, okay, like let's go, and they're like, I can't, and it's like, it's happening. So getting them to actually like open up their legs. So for the delivery, we have them pull back on their legs. And that opens up the pelvis and will give you a lot more room for baby's head to come out naturally, for the baby to rotate, and for the baby's shoulders to come out. So if they're climbing up the bed or wherever they're at for you guys, and pinching their legs closed, that's when you're gonna have a higher chance of like shoulder dystocia and issues with baby, versus if you can get them controlled to open up their legs, then that does 90% of the work for you. And so specifically, a lot of it is just like coaching, and the mom's always like, they feel like they're gonna die. Like, you know, you see a lot of people who are in medical crises, and you know, I don't know the mortality death rate, but for currently, if they say that they're gonna die, they're in a ton of pain, they feel like they're going to die, and then they obviously don't. We have nice healthy moms and babies every single day. And so getting them to take control of the situation, reassuring that like you're in a safe place, we're taking care of you, your body's doing it, and then that will allow them to semi-relax a little bit to do the work themselves.
Yeah, I agree. I think all moms are different, and some of them like do it like a champ, and some of them are, you know, are trying to crawl away, trying to run away from the situation that they're currently in. And you can really see that, like Jalee was saying, they want to close their legs. They're like traveling up the bed or away from the baby. Those are all signs that you're not pushing the correct way. Okay, a mom needs to have her hands behind her legs, so she's pulling her pelvis open and pulling her legs back. It gives her some leverage as well. And then it also causes her to kind of wrap around her baby, wrap around her belly, and push downward. She needs to be pushing downward. If she's screaming during contractions, very often that means that she's not pushing appropriately. You want her to bear down, you want her to kind of grit her teeth and really push into the contraction so that we're pushing baby out. If she's arching her back like this, and she's gonna naturally want to try to close those legs, and she's crawling away from the baby, that, like Jalee said, you're gonna have more likelihood of complications during that delivery. Okay, so it takes a lot of coaching. It takes, you know, breathe through your contraction, breathe out. Let's not scream if you can.
Or honestly, just relax, and then if you get them to open their pelvis, the contraction will push out the baby. Like the mom doesn't even need to push sometimes.
And the contractions come in waves, right? So you know, so the mom knows when a contraction is coming on, so she'll say, okay, it's coming. So then you can kind of prepare, okay, let's bear down, let's grit our teeth, let's push into it, let's wrap around baby, let's push downwards. And then the contraction happens, and then she gets a 2-minute break. And then during those 2-minute break, you're gonna say, okay, relax, chill out, take a breath. It's gonna be okay. Everything's going okay. All right. Umbilical cord clamping. So now you have your baby. The baby's in your hands. The baby's still attached. Don't forget that. And you're gonna clamp the umbilical cord 2 inches away from the baby's belly button, and then another 2 inches, and then you cut in between. The umbilical cord is really fat, juicy, thick, and so getting that clamp on there, you want to make sure that you get it on there really nice and solid. I think you probably have the same clamps that we do, and they lock into place, which is nice. I would assume, yes? Okay. You're not doing hemostats or anything? Okay, good. Okay, cut between it, and then this, my opinion is don't worry about it.
Yeah, I like it. Just kind of take a breath. Like that's the big thing. The baby just came out, whether it's screaming or not. Just take a breath. You don't want to put the baby all the way up. Like the tendency is like, okay, I have this thing. What do I do with it now? And like kind of pass it to mom. And then moms have the tendency to like try to bring it up to their chest, and the cord is not long enough. So like when we do deliveries, we just keep the baby on the belly, and then that's a good length until you do the cord clamping. So essentially, baby comes out, have a good grip. I personally, like, you're not gonna hurt a baby. They just came out of a hole like this big. So when I'm like controlling the delivery and holding the baby, it's like my hand is around its neck, and I actually hold the weight of the baby around the neck, and then I cannot drop it. And then the other one just like has the feet. But you can hold it however, it's just gonna naturally kind of come out at you anyways. But don't be afraid of like holding the baby. And then kind of put it on the belly, give everyone a second, because then at that point your attention really is kind of transitioning into baby. Like, is baby breathing? What do we have to do next for that? And so you kind of naturally forget about the cord, forget about that. So it does kind of naturally come, I think, with about a minute of like okay, baby's doing okay, now let's clamp and cut the cord.
I agree, but I wouldn't sit there and like have a timer and be like, okay, we're gonna wait for 60 seconds now. I wouldn't worry about that. I wouldn't worry about going under. I wouldn't worry about going over.
Yeah.
Just do what you're gonna do. Okay, so don't stress too much about the delayed cord clamping. There was some evidence there for a little bit that they thought that that there were some benefits to delayed cord clamping. I think they've kind of nullified
They're
that
back.
at this
They did,
point.
and then they're back last couple
They're
months
back to
ago.
delayed cord clamping now? Okay, so just like all medicine, it just changes with the times. All right, care immediately after birth, dry the newborn, stimulate breathing, keep warm, clear secretions if needed, avoid routine suctioning. So, yeah,
Side note, I was asking, I was just with a midwife before I came over this, and I asked her, told her we're doing this, and she's like, make sure you tell them for like the baby drying, I forget, your tinfoil blankets, are not good for babies, because the babies are very wet. So the first thing we do is like, you need to dry the baby. If you just wrap it up, they're gonna stay cold, and that's the biggest thing for babies specifically, is like when they come out, grab a towel and you essentially like rub them down, and you want to get them screaming, of course. So what we do, we like tickle the feet, you rub the back, you can even like tickle the armpits. You just are trying to piss off a baby, and then it will scream its song off and transition totally fine. And so again, be aggressive with the baby. It just came through a tiny hole, it can handle it. But make sure you do a real blanket, towel, something to get their skin dry.
yeah, and you do dry pretty vigorously. I mean, you sit there and you rub that baby down and you rub each individual leg and rub its torso, and that vigorous rubbing is going to get the baby generally stimulated and breathing. But so yeah, don't worry about going too soft on it.
A quick question about the suction.
Yeah.
So I think a lot of times people are taught, like, you should suction when the head is delivered, but maybe the rest of the body is in there, because once the thorax comes through, then that, deep breath happens, and so then they take in everything. So do you routinely suction? Are you suctioning nose before mouth, mouth before nose?
So that is, again, one of the things that is up and down, and at the moment, that's one of the old school things, and with the new delayed cord clamping that just came out a couple months ago, they say don't suck. Don't suck at all. You're not supposed to suck on the perineum anymore. That dropped away a couple years ago.
Suck on the perineum.
Do the bulb syringe while the baby's head come out
Gotcha.
before the body comes out. They used to do that. That's totally out of the window now. And then now you put them on the belly and then do the syringe on the belly. But even now, we don't do that. So technically, you're not supposed to do any suctioning at all.
When
So don't worry about it.
the baby screams and is coughing, it clears its own secretions. It's really interesting. So I did all of my OB with as a resident, and so I worked with all different sorts of OBs, and it was really interesting to see every single OB is going to do something a little different from another one. Every single one of them, and so. If they get mad at you for not suctioning, or then the next one's going to get mad at you for suctioning, and so it's just one of those, I think, provider preference kind of deal. But if you don't need to clear the secretions, then don't.
Do you also recommend, sorry, I'm annoying back here.
You're good.
Clamping the cord? I think the one or couple experiences I had clamping the cord is like clamp them close together, because the further out you clamp them, now you've got all that blood that's in the piece and it's just gonna make more of a mess.
Yeah, it's just a cleanliness thing. It won't impact baby at all. But putting the clamp on, and then I put the clamp on, and then I'll kind of like milk the cord or squeeze it before I put the second clamp on, just so then where you're cutting doesn't have a bunch of blood coming out. It won't, hurt anything or lose blood. That blood's already lost to mom and baby anyways, but it will make it a little bit cleaner that you guys aren't covered in blood if you just clear it a little bit.
Yeah, and again, those cords are thick and meaty. Okay, so when you clamp them down, it's not the easiest thing. And then if you're going to milk the cord, it takes a bit of pressure to milk that cord just because they're pretty thick. But yeah, I'm notorious for just putting on a clamp, and capturing that blood in between the two clamps. Then you cut it and it sprays, and so yeah, it can be nice to milk it if you can. And then at this point, you can take a breath and kind of, because this all happens pretty dang fast. But after this, then you can maybe take a breath. But this, of course, is when everything goes according to plan. And honestly, I know I was being facetious before, but honestly, things go according to plan, like in a normal delivery, actually pretty routinely. So I wouldn't always expect that there's going to be a complication or, oh crap, what's the bad thing that's going to happen here? I mean, of course, that's always in your brain. But like Jalee said, moms have been doing this at home for millennia, and very often, well, more often than not, there's not complications. It is a normal delivery. So I think it's okay to expect that you're going to have a normal delivery, but just be aware in the back of your brain in case you do have a complication. And we'll go over what those are.
And can we cut like right after we clamp or?
Yeah.
Yeah.
Yep.
If you clamp, there's no more blood flow, so there's no reason to like clamp and then do delayed cord clamping for a minute because it's not passing. So just clamp and cut.
Question.
Yeah.
With the delayed cord clamping, is that kind of like we're watching the pulsing of that cord? Is that kind of what that's
Yeah,
referring to?
you
Waiting
can.
for that to stop?
Yeah, it takes like 3 minutes for the blood to stop pumping between the placenta and baby, kind of on average. And so we will in the hospital have like our timer for the APGARs, which you guys are supposed to be paying
We're
attention
going to
to
go over
anyways.
that.
And so there's should be a semi-clock in the background, but 3 minutes or the new like, modern crunchy mom push is like to wait till the cord is white. And so then there's no more blood flow at all, and that's like, I don't know, 5 minutes. So it's
It
not a super
really
long
doesn't
time.
matter. This
It
is
really doesn't
this
matter.
is why I'm here.
Yeah.
It really doesn't
really doesn't
matter.
matter.
Don't worry about delayed cord clamping. Honestly, you have enough to worry about in this situation than to worry about, oh my gosh, how long has it been? Should I wait? Should I not wait? Just don't worry. Just clamp the damn cord and cut it. Okay. All right. So care of the baby. APGAR scores. Who knows what APGAR stands for? You guys reviewed this before, right before this. No? Good for you guys. That's awesome. I love that. I mean, honestly, if it were me, I'd have my little card out and I'd be, going through it. Good job, guys. That was awesome. Okay. So you do it at 1 minute. You do it at 5 minutes, as you guys know. You know all this already. And scores range 0 to 10. Care of the mother after delivery, monitor bleeding, monitor vitals, allow placenta to deliver naturally. So you've now cut the cord. The cord still, the other half of the cord that's still attached to mom is hanging out. You're taking care of baby. You're rubbing baby down, making sure baby's breathing and screaming and all that stuff. Then you're gonna hand the baby off to mom, and then you're gonna allow the placenta to deliver naturally.
It can naturally take up to 30 minutes. So really, like, leave it alone, don't touch it. Like, make sure they're not hemorrhaging out. But, like, I do not expect you guys to deliver the placenta. It might come out on its own. The mom, might feel an urge to push, and you say, okay, give it a try, give it a push. But honestly, most of the time when we get outside deliveries, the placenta's just sitting in the vagina. And then they come in, we get the placenta out of there and do repairs and that sort of stuff. So I just don't pull on the baby, don't avulse the cord, because then mom's hemorrhaging and baby's hemorrhaging. But if you just leave it alone.
So, in your opinion, after they've cut the cord,
Don't touch it.
Don't touch it. Just leave the bottom half to do what it's going to do. The placenta, yes.
So does the placenta still have to detach inside after birth, or is it?
It does.
Sometimes during birth it's detached.
Yeah. It detaches after birth, as long as it's a normal delivery. If it detaches beforehand, then baby's not getting blood flow, and that's a bad baby emergency sort of situation, which you guys won't know. We only know that through monitoring. And so the average is kind of 7 minutes after baby comes out is when the placenta will kind of separate on its own, but we don't touch it for 30 minutes.
Just out of curiosity, I've seen some ER doctors pull on the cord, and
Yeah.
the patient has been hemorrhaging for a while.
Yes.
How
Yes.
is that good?
Yes, so if they're not hemorrhaging, don't touch it. But then that's the question of, okay, well then when do you need to touch it? So if they are hemorrhaging, then you do want to help get the
And
placenta
it's
out of
violent
there.
like that, like a tug of war.
It shouldn't be. That's
Okay.
that means something's kind of stuck. Most of the time, it's just a little bit of traction. Like, I don't even, just like the weight of a water bottle. Kind of just like pulling on a water bottle.
So if she's standing here and she's gonna stand on one,
What are you
just no, do both feet planted. it's kind of enough tension to kind of pull her towards me like this.
And that's it.
That's it. So it's just enough right here so that I can get her to come towards me. And it's continuous pressure, and you have that clamp on there. You're gonna put, you're gonna put the clamp, the cord like in between your fingers here, and then you're just gonna give that continuous pressure. And like I said, it's just enough to like
Get some
pull
back
someone
pressure.
towards you.
Yeah.
So it's not a lot. You really don't want to avulse a cord. Have I ever avulsed a cord? That means that you pulled the cord too hard, it's ripped. Have I ever avulsed a cord? Yes, I have. Has Dr. Humphreys just done one recently? Yes, he has. And he called Jalee to come and fix it. Have you ever avulsed a cord?
Kind of. Well, but I'm gonna go in there and get it anyways.
So she doesn't care if she does. 'Cause
Yeah,
she
so
can. So
Massage help to deliver?
Yes.
we're gonna get there. Yep, absolutely.
That's
So
the key, what I actually want you to do instead.
preemies.
Yeah.
Preemies, you have to be, that's the one where you have to be the most careful with those cords, because those cords are delicate and dainty. Okay, so you really, if it's a preemie, I almost wouldn't pull on the cord at all.
Yeah.
Even if they're hemorrhaging, I probably wouldn't pull on the cord at all if they're a premature delivery. If they've gone to term, meaning they're like 37, 38, 39 weeks, something like that, then you're better off than if they're 29, okay? So, if they're a preemie, I probably wouldn't pull on the cord at all. That's my
Well,
2 cents.
And again, like, we aren't doing that, right?
Yeah, my question
Unless
was
you're
just
hemorrhaging.
from
Yeah,
observation.
unless you're hemorrhaging,
If
which,
it takes 30
But yeah.
minutes, we're gonna give TXA
Yeah.
to help with the hemorrhaging,
Yeah.
and we're gonna be at the hospital.
Yeah.
I don't,
Yeah.
yeah.
We're sitting on scene for 30 minutes, we've done something wrong.
Right. You've had a question for a while.
Yeah, so with wiping the baby, like wiping them off, I've heard, and maybe this is, you're referring to crunchy mom thing, maybe this is a crunchy mom thing, but like leaving the baby in the secretions and stuff, is that actually beneficial to baby, or is it more beneficial to wipe that off and get baby dry, or like how quickly should you be doing that? You're saying then put baby on mom's belly, kind of take a second, like everything's okay, and then wipe down, like how quickly are we wanting to do that, how?
Yeah, so there is a little bit of a difference between like all of the fluid and then the vernix is like the cheesy white stuff that babies get covered in. And so the crunchy granola mom thing is to like leave the vernix but take off the fluid. And so I feel like that's a little bit more nuanced that like, I mean, your number one priority is to have a healthy baby and that includes normal temperature. And so I would be a lot more aggressive with that versus being like the mom being like, oh, I want to leave the vernix on. Be like, well, I want your baby to like not die, so I'm gonna take we're gonna rub it down. And so there's a little bit of the balance, but theoretically, you take off the fluid and leave a little vernix and do skin to skin. and they're
Yeah,
fine.
so if you don't know, babies are cheesy when they come out. They're covered in that vernix. And so you don't need to worry about getting that off. You don't need to sit there and try to rub off the vernix, or you don't worry about that. It's really just the clear liquid secretions that are on the baby that
And
could
blood.
potentially, and the blood that could potentially make the baby cold. But don't worry about the cheese. Babies are cheesy. Just let them be cheesy. Okay.
Sometimes it comes off really easy, sometimes it's stuck on there.
My baby's too cheesy.
Just wipe it.
Some babies are real cheesy, but you had a question, I think.
I just wanted to follow up with what he was saying, like, we should not be pulling on cords.
Period. Okay.
Absolutely
I would
not.
rather you guys.
We have 100 other, not 100, we have
Other
other
things to
options
worry about.
in hospitals where she's at.
But there are some things that you are going to have to do, and we're going to get to those here. So
Yes.
you do your Pitocin every single time, 100% of the time,
Yeah, every patient.
okay? So it doesn't matter who the patient is, you need to give your Pitocin.
After the placenta delivers,
It doesn't matter.
Who has their protocol? Whip it out. I want to see. Because I got this from your protocol, so
It's just for hemorrhages, what I thought our protocol was.
Also thought, make sure that we can.
I want to
have
make sure
baby
that I'm
number
not
two.
teaching.
Yeah,
you
and baby
something.
number 2. Yeah, because if it's twins, then you don't know, and so you don't give it until the babies are out, but
Read it out for us, Abby.
we assume. Hey.
I never went on that. Yeah, our drug thing says just for postpartum coverage.
After placenta.
After the placenta.
Ours
Looks real suspicious.
Yeah, I am suspicious because I swear that I
No,
looked at this
it's
and
in
this.
there, you read it
Yeah.
right, it says oxytocin 10 units IM after newborn delivery.
Okay, that's what I thought. It's on the first page, right?
Postpartum
Yeah.
emergency.
Yeah. So you didn't have the first page on your thing. Right?
There's extra, there's extra pit for hemorrhages. So there's kind of a standard pit and then extra pit, but
Just funny.
but go based off your guys' thing.
Okay. All right, so that was a good point to clarify. I think you're doing Pitocin on every mom after baby's delivered.
You will not hurt anything with 10 units of pit.
Okay, and you could potentially help. So I think that's a good thing to do.
And then it's after baby. It's technically, like, it doesn't make a difference whether it's like after or before the placenta. It's beneficial either way, but your goal is we have to get the baby out first. Hence the concern about twins. If there's 2 babies, you have to wait till all the babies are out.
So,
They should hopefully know that.
They should hopefully know that.
so the times that I see you guys doing this is like, we talk about like stay and play or throw and go. Like if this mom is having a baby, like don't deliver the baby while you're in a moving ambulance. Just like we don't do CPR in a moving ambulance anymore. Like you're gonna stay and play for a minute, you know, and while everyone's doing stuff, everyone's gonna have their role or whatever, somebody can be pulling up some Pitocin and give it, you know, so then you're just transporting 2 patients, you're not delivering while you're moving. So, you know, I think it's good if it's in the protocol. It's gonna help everything clamp down, deliver the placenta, help moms bleeding afterwards. There's a lot of benefits to it. And so I think, you know, if you're delivering on scene, like if you're rolling in and you're delivering in the ambulance bay outside the hospital, please don't sit in your truck waiting to give pit. You know, like, if this should be intuitive if you're on scene, you know, and you've got the time right after. I think it's worth it.
Okay. All right, I'm glad we clarified that. Maybe we learned something today. All right. All right, when things don't go according to plan, we're going to talk about all the different crazy, scary things that can happen. We're just going to kind of run through those. So this is a very common one. You see this, I don't know, maybe 50%, 30% of the time that you have a baby that delivers. Even if they deliver completely normally, the chances of seeing this is pretty good. Where they have the cord wrapped around their neck, it's really not that big of a deal. Generally, you're just going to grab that cord, you're going to pull it over its face, and you're good to go. Every once in a while, you're going to have it wrapped around twice or 3 times, or wrapped around a leg and the neck, and then it's really tight. The cord can be really tight, and you're going to know almost immediately if it's loose enough that you can pull it up and over, or if you can't. And if you can't, it makes everything a little harder. So the second that baby crowns and you see its neck, if you see a cord around it, you can try to take that cord off right then and there. If you leave it on, it can make it so that the cord's really tight and that the rest of the baby can't come out because it's being held back by its cord. So you want to try to, and it's a very natural thing. The baby's coming out, you see that cord, you just grab it, pull it up and over, and then you just keep going.
Yeah, the baby's either gonna come out with the nuchal cord and there's gonna be enough room, or they're gonna get stuck.
How long are the cords usually?
Anywhere between this long to like that long, and so that's why usually like once baby's out, belly area is safe, but if you try to go up to the chest, there's not enough distance, so that one.
And then if you can't get it up and over the face, which does happen, and again, don't be afraid to use a little bit of pressure and force to try to get that cord up and over, because that's a lot easier.
A little bit, if they've also the cord,
A little
they're
bit.
very mad.
A little bit. But double clamping can be just as difficult, because if it's already so tight that you can't get it up and over the face, it's going to be pretty tight to even get clamps on.
Yeah, because like you're working in this
space
right here, and if the head's stuck and you have the mom's like vaginal tissue right here, it is very hard to like get in there.
Get in there and clamp it off. So do your best. And then same thing here, like cutting cord between the clamps when it's already really tight. That's kind of a scary thing. It's a hard thing. All right. Neonatal resuscitation. You have a whole protocol. We're not going to really hit all that here, but for that, I will say that if a baby comes out blue, if a baby comes out gray, it doesn't necessarily mean that your baby has died. I've seen tons of babies that come out that you go, holy crap, that is a scary baby. And they go over, they warm it up, and they rub it down, and it takes a minute, and the baby takes a deep breath, and then everything's fine again. So appearances can be deceiving when it comes to babies, okay? So if you see a baby that comes out and looks scary, it's like an oh shit baby, there's a good chance that the baby's just fine. It just needs to take that first breath, and then it'll get its color, and it'll be okay.
50% of my regular deliveries, the baby comes out and the dad's like, are they supposed to be that color? I'm like, yes. It's okay, everything's fine. And that's just a regular delivery.
And I've seen limp babies, like real limp babies come out, and I was so scared, and then you hear the cry, and you're like, okay, everything's fine. So if you see that, I just don't want you to be too scared that something bad has gone wrong. Maybe it has, but not necessarily. Cord prolapse. This is a Jalee.
So essentially, which is why you want to look but not do a like full digital exam. But if you get to the patient, they're bleeding, look if their water's broken, and then you might see this little like white snake-like is I guess how I would describe what the cord looks like, hanging down out of the vagina. The concern is essentially that's baby's oxygen supply. So when they're having a contraction, that head is cutting off the oxygen supply. And so you need to decompress the cord. So essentially you put 2 fingers into the vagina and lift up baby's head. You don't want to really like touch the cord as much as possible because they spasm, they get irritated if they're touched. So you're really just on baby's head trying to push the head up so then that cord isn't being caught. And there's a couple different positions, like the Trendelenburg, so just really tipping mom back so then baby kind of like falls back up, can get the baby off of the cord and off of the pelvis, or doing like the hands and knees, kind of flipping them over and having them with their like head down and butt up in the air. That will also help drop baby just to get it off of the cervix.
So you just want that head to come off of the cord as much as possible. Very often when you do that, you can kind of push the cord to one side or another, and then when the head re-engages, it's no longer pushing on that cord.
But don't do that, don't touch the cord. I don't want them touching the cord.
Right, but what happens?
That's what I do.
So, okay, so tell me this. So if they push up and they can get the baby's head off of the cord, then
just
what?
hold it.
Then you just want, okay,
Yeah,
so this is
hold
a
it.
hold
This
and
is-
jump in the ambulance,
yeah, this
and
is
someone's gonna have their
a
hand.
ride the bed where one of you guys are in the back keeping the baby off until you get to the hospital, and then we do the same thing. We have a nurse switch you guys off, and then a nurse rides the bed down to the OR until we do a little hand tap in the vagina through the C-section.
Okay, so everybody understands that scenario? You're gonna push up on the baby, get that baby's head off of the cord, and then you're gonna hold there with your hand in this woman's vagina until you get to the hospital and someone else does it. I don't mean to be gross, I'm being serious. You're gonna have it's literally, you're gonna sit there and be holding this, and it's gonna be a long ride, but that's what's best for the baby, because the second you take that hand out, that head re-engages and is on the cord again, cutting off blood
Even for our
circulation.
nurses, it's like we're going back for a C-section. We put the big blue drape over them, and they're just stuck in there, like hanging out with their hand in the vagina.
All right. Postpartum hemorrhage, this is a big one. I don't know what percentage of moms bleed, but I feel like it's a lot. I mean, I've done a lot of postpartum hemorrhages in my day. Jalee has qualms with the definition here.
It's 1,000. They changed it to 1,000.
So your protocol is 500 milliliters. It's 1,000. Now, have you guys ever done? I'm sure you guys do all sorts of trainings, I know, but have you guys ever done like a hemorrhage training where they show you different like amounts of blood and what it looks like? Nothing like that. We were talking about doing something like that today. I can fill like an entire chuck full of blood, and you still haven't reached 1,000. I could probably do 2, maybe on your 3rd one, that's when you've reached 1,000. So it's a lot of blood.
Towels, yeah, or like 2 towels.
Okay,
full.
so these are, this is one of the reasons why I love OB. It is bloody, and you get dirty, and it is awesome. So, but you can see a lot of blood, and it doesn't necessarily mean that something's wrong. If the definition now is 1,000 milliliters of blood loss, that's a whole liter of blood. That is a shit ton of blood. So if you see 500, maybe she's not hemorrhaging. Maybe that's all part of the natural birth. Okay, so there is a lot of blood involved in this.
And they will continue to bleed afterwards, that's part of it. Like sometimes we see people come in that they like will pack them vaginally because they're concerned that they're still bleeding, and essentially all you made was a tampon because they're still going to continue to bleed. The uterus will bleed, the placenta will bleed, the lacerations will bleed. So that's, I think, the hardest thing, gonna be like, okay, what's normal amount of bleeding versus what's an abnormal amount of bleeding. So.
Yeah, if you guys ever invite us back, we'll do that little activity. It's fun because you try to guess how much blood is on the is there, and it's really hard, and no one can do it. It's really difficult because you look at this giant ass clot and it's like, nope, that's only 200 milliliters, and you're like, that thing is massive. So anyway, so there's a lot of bleeding that is involved. Just because they are bleeding, it doesn't necessarily mean that they're hemorrhaging necessarily. I mean, I guess by definition that's a hemorrhage, but you know what I mean. That it's not a postpartum hemorrhage necessarily. Like Jalee said, they could have a laceration inside, and meaning that they are still bleeding inside of their vagina. So clots may be coming out. If you see clots, again, that doesn't necessarily mean that we're talking about necessarily a postpartum hemorrhage. Maybe that's just part of the normal from the laceration that's in there.
Or it could be the placenta.
Or if we've reached the threshold of true postpartum hemorrhage, then we need to know what to do from there. What is the most common cause of postpartum hemorrhage? Like 90%, yep, is the placenta being stuck in there, okay? Does anyone know what the term for that is?
Placenta stuck.
Placenta stuck. So I think I heard it.
Yeah.
Atney. Did someone say atney?
Yeah.
Did you say atney? Okay. Yep. Atney. So I remember in medical school and residency, the slide would come up and it would say, "What's the most common cause of postpartum hemorrhage?" Atney, 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 and then there's like 3 things at the bottom. Okay, so most of the time it's going to be that there's placenta that is stuck inside of the uterus that hasn't detached, hasn't come off. What is the number one thing we're going to do? And in fact, you're probably going to do this during your normal deliveries as well anyway. So what thing do you need to do to get that placenta to detach? Fundal massage. Has anyone massaged a fundus before? A couple of people. You know that you are massaging a fundus. You know it. You can feel it. It's very clear. It's this really hard softball size thing that's inside of their belly, and you just sit there and with your fist you just kind of mush on it, and don't be afraid of putting quite a bit of pressure on that thing.
The mom's gonna scream at you.
Because it's uncomfortable.
Bleeding, and yeah, you say again, I'm sorry, I know this hurts, but you're bleeding and we need to get this taken care of.
Now, I know you guys aren't pulling on cords or anything, but even when we have a normal delivery, when I'm pulling on the cord trying to get the placenta to detach, I'm sitting there and I'm going to be massaging the fundus in every single delivery, trying to get that, because when you massage it, then it detaches from the uterus and then it comes out. So that massage really is like game changer. You want to be doing it in most of your deliveries, if not all your deliveries. Massaging that fundus, which gets that uterus to contract down, and then that placenta comes off. And so, all right. Okay, yeah.
So that should be with almost every. Sorry. With almost every delivery, not just if you're.
Yeah, you can always massage a fundus. You're not going to hurt anything.
Okay, so baby comes out, you can start.
You can sit there and massage it. Yeah.
If the patient will let you, if they're not bleeding, if like bleeding's going okay, then you can be a little bit more hands off. But obviously if they're bleeding, then that's when you throw the mom's comfort out the window.
Rude.
Don't worry, the call's a hemorrhage. Every time, it happens every time, no matter what the training is.
This is another reason why I came, just because Jalee as well could get called away at any time. She's not being rude, just her life. All right, here's the quiz. None of you guys probably know. Anyone know this band? No? No one can name the band? All right. Okay. Blood, gallons of stuff. Treatment of postpartum hemorrhage. Fundal massage, oxytocin, oxygen, IV fluids, TXA rapid transport. Fundal massage, I put that one in the biggest box here. We talked about it already. You want to massage that fundus, yeah?
I just want to make a side note. I love TXA.
Oh, yeah.
It doesn't do anything for an immediate acute postpartum hemorrhage. It's like a 2 to 3 hour like medication.
Does
So
anyone-
still give it, but like it doesn't do anything for you guys.
Does anyone know what TXA does? It's really interesting.
It's an antifibrinolytic.
Damn.
He likes the biochemical.
Who's this
I
guy?
can regurgitate information like crazy. I don't know what it means, but I can.
No, it is an antifibrinolytic. That just means that it prevents clots from being broken down. It doesn't prevent new clots. It just prevents existing clots from breaking down. I looked this up last night because I was really interested. So in Jalee's practice when she was in residency, I think wouldn't you give every patient TXA?
Postpartum hemorrhage risk scoring, but yeah, essentially most people got TXA. But
So-
it's preventative.
Right.
Like it's not active.
So, and that's really interesting. So, where I trained, we would only do TXA if you had a postpartum hemorrhage. But where she was, it was like a good chunk of your moms,
Yeah,
your
it's
normal
probably
moms, were getting
60,
TXA,
70%.
which I thought was really interesting. So, again, if you're worried about a hemorrhage, you're not going to hurt anything by giving TXA. So, don't. Ish. Okay, go on.
There's some newer stuff with like kind of with AFEs and things that the TXA might worsen the rate of AFEs, but we don't
Obviously, I thought that was intuitive.
I
I was gonna say that, but I thought it was so obvious.
It's super nuanced. I was honestly actually really surprised that TXA was on your guys' protocol. I mean, it is a safe medication, but it really doesn't do anything for you. Like we'll give it in the hospital if it's needed, but again, it's not going to
So
actually
if
do
you have to
anything.
pick between PIT and
Pit.
TXA,
Pit.
So Pitocin causes the uterus to contract down. That's what your fundal massage does as well, right? So, and that's exactly, again, atony is your number one cause of postpartum hemorrhage. So you want that uterus to contract down. And you can tell, actually, if you've ever felt a boggy uterus, we call it a boggy uterus. So when you reach up there, if that uterus is not like a softball, it feels like it's hard like a softball, and it's kind of squishy, it means it's it means it's a squishy balloon. It's boggy, which means that uterus is not contracting down. So if you ever reach up there and feel it and it's soft, you want to be massaging that because you kind of want to wake it up. Hey, buddy, you got to contract down. Because if it's boggy like that, it's going to bleed. Okay, because it's not doing what it needs to do. It needs to contract down and it cuts off all that blood supply. Okay, so another reason why we do fundal massage is because you can feel that fundus. You can go, holy crap, that thing's not waking up. Come on, buddy, let's get going. Give the Pitocin, do the fundal massage. Usually it figures itself out and contracts down, and you can feel it. I mean, in real time, you can feel it go from boggy to hard.
It's a little hard if the patient's 300 pounds, but like under 300 pounds, you can feel
But
it.
they don't ever deal with patients that are 300 pounds, right? Okay.
Question for
Yeah.
the treatment of hemorrhage, the IV fluids. I don't know, I feel like I'm thinking of these patients as trauma patients now, and if they are hypotensive, I'm thinking permissive hypotension, because our IV fluids isn't going to help anything. So is that, am I thinking of it like as a trauma patient, or are you still like, yes, let's give them fluids, because my thing is like they need blood?
Yeah, it's still fluids because we will do fluids before blood because a lot of times it will help just that like low baseline hypotension. If it's like truly that severe, they will get blood, but they still need fluid volume resuscitation in general is better than nothing. So if you have the time to look at the
Do you agree with
fluids.
that? Do you?
Yeah, I think that's good. I mean, we talk in trauma about permissive hypotension and kind of this idea of you don't want to pop the clot. You know, if you put too much pressure into the system, then any clot that's there, you're gonna pop out and they're gonna keep bleeding. So your transport times on this, you're not dealing with a long extrication, you know, so hopefully, you know, by the time you get a liter of fluid in, you're there. You know, we don't want to dilute what they have in their system with too much fluid, but, you know, giving them a liter for sure is reasonable.
Yeah, and most moms through the labor process in general are come in dehydrated because they're contracting and they don't feel good, and so they're not eating and drinking, or sometimes labor causes diarrhea. So pretty much every laboring patient at baseline comes in volume depleted already. So.
Okay. And then oxytocin, if bleeding continues 10 units or 20 units, and start the infusion.
Yeah,
So-
so in the hospital we give 30 units, so that's why it's like your 10 is going to be fine.
Okay. I was thinking Cytotec. They don't have Cytotec. Yeah, okay. All right, well, you all failed my test. Who knows this band?
Oh,
Okay, thank you. Alright, that was the band. Alright, so when things don't go according to plan, part 2. So, breach presentation, Jalee, you wanna take this one?
Yeah, these are not good stuff. Again, essentially being as hands-off as possible. The big problem with breech is like head entrapment, that if you're like pulling on the baby before it's ready to naturally come out, then you're gonna like, kind of how you can like cause a shoulder dystocia if the mom's climbing away, you can also like cause a head entrapment with these breech. And so sometimes it's the feet coming out first, in which case you have the legs hanging there. If it's the butt, you just let it come out. You literally just kind of get the mom in a good position so the baby's hanging and so you have space, and so at the edge of the bed or at the edge of your gurney, whatever it is, so then gravity can help drop down the kid along with mom's pushing. So kind of butt comes out, you just watch, you wait, you don't touch anything. Eventually, depending on where the feet are at, they'll pop down, and then the body will then pop down with kind of that next contraction, and then you're looking at the arms are usually up by the head, and then as they push, you can do like a little bit of like pressure just to bring the arm down, but again, even that, they'll eventually come out on their own until you're literally like staring at the head, and then you essentially let it drop out. They kind of go into a little bit of like trying to create an airway if the head is entrapped, by like pushing on the vaginal tissue and suctioning the mouth and things like that. And then in the super severe prolonged cases, they go into kind of like how you tuck a fetal head. And so as the baby is hanging down there, you are trying to get the head to like tuck down a little bit, like putting the chin to the chest, and so you kind of grab the you don't grab the eyeballs, but you grab right at the orbits and then on the chin, and then you pull down on the baby's face, because this angle is a lot smaller than this angle. No, it's not a good thing. Essentially just try to get to the hospital.
Yeah.
Because the head entrapment is
You know,
baby.
I think we all understand at this point that like there's some things that like, I mean, you guys have experienced it yourselves, that there's really nothing you can do. And
pressure with the right foot.
and yeah, and really like shit's going south, and you know, OB's a really difficult area because I mean, this is the most precious thing to this patient. This baby that's coming out is the most precious thing to this patient. And so we as humans and as Americans, I think we tend to feel like that nothing should ever go wrong, and that we should, because I'm pregnant, I should have I'm entitled to a healthy baby, and I'm entitled to a healthy delivery and without any complications. And so then if there are complications, then we're pissed. And I don't think we have any buffer as a society, as we don't have any buffer that, hey, you know what, sometimes things don't work out the way we plan. And that can, as you guys have probably already experienced, falls on you guys a lot, and it's unfair, and it's not right. It falls on OBs a lot, and that's why they get sued more than any other doctor, because we don't want anything to ever happen bad that happens to our babies, but unfortunately things do happen. But this is one of those situations where, yeah, more pressure on the right foot is exactly the
We
right
don't
thing to
even do breech vaginal deliveries anymore. I mean, if you guys roll in and if there's just a head left, we'll try to deliver it. But if you roll in with like feet hanging out, I'm doing a C-section. Like I'm getting that baby out through the abdomen because they're such high risk.
How soon, I guess, can the baby kind of like flip? Like, let's say they had one of their appointments just like a week prior or something like that. How fast does that kind of happen?
Any day.
Immediately.
Yeah, like you really don't
Yeah.
know. If they're like full term, then the babies typically run out of room and shouldn't flip, and so it shouldn't be a concern. But especially if they're like, I don't know how far along I am, or could be like 20 weeks, 27 weeks, like those babies are up, down, and sideways in there. So you really want to kind of see if there's a head coming out. If there's not a head coming out, get to the hospital.
Yeah, and even that is tricky. I mean, there have been times when I have an ultrasound in my hand and I put it on the mom's belly, and it looks like a head that they're head down, and it's not. It's a butt, and even with an ultrasound, it can look like that. And so or they could have had like a version. They had one just like even the day prior they had a version or whatever, and baby's flipped back around and is breech yet again. So if you have any suspicion that you have a breech baby, just get them into the hospital as fast as possible so that Jalee can do a C-section.
I actually got a question for you.
Yeah.
So on some sort of a breach, things gone wrong situation with the delivery, and mom, lives here in Layton, but, they're delivering at McKay, but our closest hospital is IHC. Are we going to IHC?
Closest hospital, yeah.
Yeah. Yeah, at this point,
As long as they have, if it's this scenario, closest hospital, but essentially it should be whoever has a labor and delivery, which we're fine in this area, but if you were somewhere more rural where you have the option of going to, not they're all up here have them, I don't know, when this.
But like the Malad Hospital versus Pocatello, where I was, like you'd rather have them go to Pocatello.
You want them to go to a labor and delivery unit, because
Then-
they can't do a C-section. If I'm wheeling in the patient that needs a C-section into an ER that doesn't have labor and delivery, they're gonna look at us like, what am I supposed to do with this kid?
You
Yeah.
don't wanna take them to Davis West.
Yeah.
Yeah.
Yeah, or I was gonna say, when the Syracuse
Skip Davis
Community
West.
Hospital, if they don't have their
Davis
labor and delivery, don't take them there.
So if
Yeah.
they have an L&D, they can pretty much
Yes.
Do anything.
everything.
Yes, they can do everything. Yep. And I was a little doom and gloom. There are plenty of breech deliveries that happen and nothing bad happens. All the breech ones that I've had have gone okay. I did them with old school doctors who wouldn't do C-sections, who would actually do vaginal breech deliveries. Like I said, I worked with a ton of different OBs, and so that was kind of fun. Not that I'd ever want to do it, but just because they are breech, it doesn't necessarily mean that you're going to be in a world of hurt. All the same, get to the hospital as fast as possible. But there are plenty of babies who are delivered breech and are just fine. Shoulder dystocia. This is another one of those oh shit situations. So the head's delivered and the shoulders are stuck, and you can see it. It's called the turtle sign. You guys have probably heard that. So you'll see the head pop out, and then the head actually kind of like locks into place on that vaginal cuff, where it literally is like kind of stuck on there, and the baby's not coming out anymore. The shoulder is stuck behind the pelvic bone, and so you have to get that baby to drop the shoulder and get that shoulder out of there. This is another one of those shit situations because you don't have a whole lot of time. I don't know.
You got like 5 minutes and there's brain tissue damage.
So this is one of those situations that if you're at home and there's a shoulder dystocia, even like saying, well, let's get in the ambulance and let's run to the hospital real quick, there's a very good chance that you won't make it. That baby won't make it in that transport. So this is a very emergent situation. There are a bunch of different maneuvers that you can do to try to get that shoulder to come out. The one that I want you guys to remember the most is you're gonna put suprapubic pressure on mom. It's a lot of suprapubic pressure.
They like jump on and.
Like mom's there. I mean, it's almost like a CPR kind of pressure. I mean, you're putting your whole body weight right there, and it's gonna hurt mom. It's not gonna feel good. She's gonna wonder why you're doing this. And getting two of you, if there's two of you there, two of you to get, I mean, you're putting all your weight, all your body weight on that suprapubic, right above the suprapubic bone.
Not the fundus.
Not the fundus.
Not the top.
So the fundus
Not
is
the
up here,
pregnancy.
you're down here, okay?
You're on the bone.
And you're pushing as hard as you possibly can. You're putting all your weight on top of it. I had a shoulder dystocia once. I say it was only 4 minutes, and 4 minutes is an eternity, and you feel it because that baby's head is not moving, and you're like, shit, I know we have a dystocia. And it was me and the other nurse, and the other nurse was also a bigger nurse, and in the hospital, the bed's pretty high, like the pelvis is like at this level, and you lower the bed all the way as far as you can so that both of you guys can have that leverage to get on top and push on top of that baby. And then eventually we got that shoulder delivered, and it was okay. But then there's all the other maneuvers that you can do. You want to talk about those?
Yeah, positioning, again, super important, just getting their pelvis to open up. That will help just create more space. And then the other things that we do, essentially, you put your hands by baby's face, and you see what you can feel. Like worst case scenario, if you're like trying to like rotate and pull, if you like feel this arm, if you're pulling on this arm to get that shoulder to come out, like you're gonna you could have a clavicle fracture or you could have a humerus fracture, but those are preferred to brain damage. And so those will heal and get better with time. So if you have to, that's your next step, is to just be more forceful and see if you can get the kid. There's something called like a corkscrew maneuver where you're essentially just trying to like spin the kid out and rotate it, so then they like get those shoulders to tuck, and eventually it'll be enough where they'll kind of like spiral out.
Yeah, so again, this is one of those situations, the translation of that is that this is one of those situations where it's just do whatever the hell you can to try to get this baby out. And if you can get your hands in there and twist the baby, and there's a corkscrew and there's a reverse corkscrew, and like just put that suprapubic pressure on as much as possible, and if someone's down below and can try to twist that baby, just do anything you possibly can. Don't worry about breaking clavicles or breaking arms or anything like that. Those will heal.
But do wait for a contraction, because if you're pushing without a contraction, then you're just wasting mom's energy. And so it really needs to be with a
So
contraction
you
that
should
you're
be
doing all this stuff.
doing those maneuvers during the contraction.
With
not during-
only while
in
mom's
between when
pushing
she's
with a
resting.
contraction.
Okay.
Yeah.
Okay. Questions with that? Yeah.
Is the pressure gonna be like straight down, or is it like? some
No,
angle that-
that's a great question. It's straight with the floor, so you're not pushing downwards, because you're pushing against. I mean that shoulder.
shoulder, you're hitting the shoulder.
So if you're pushing downwards, like down towards the vagina, you're actually pushing that shoulder into the pubic bone, and you need it to clear the pubic bone. So you need to actually push kind of down and away from the pubic bone so that it will release and then come down. Does that make sense?
Yeah.
Does that make sense?
If you know what technically, if you know what direction the baby's facing, then you can like help rotate the shoulder with your suprapubic pressure. But you're probably not going to know
Yeah.
even the direction of the head, because some shoulder dystocias are because like the baby's looking this back way, and so you think you're trying to rotate it this way, but that makes it worse. So just straight down.
Yeah. Eclampsia, you're gonna give a ton of magnesium. In OB, they give a ton of magnesium, way more than so I'm a hospitalist at Davis, like I said. These guys, their magnesium levels, like, so I want a magnesium greater than 2, typically. These guys' magnesium levels get up to like 5, and like their blood level is 5. And if in the hospital setting, I'm like, oh shit, and in OB world, so they give a ton of magnesium. So if the mom's having seizures of any sort, then you want to give the magnesium. I think that's it, right?
Yeah, and then all your other protocol, like the Ativan, you guys have a protocol for seizures, so follow your normal protocol is also totally fine, especially if the mom's pregnant. You know, a lot of people get concerned of, oh, can I give this to the mom because there's a baby in there, and what if it's not safe in pregnancy? Like if the mom is not oxygenating, then the baby is not oxygenating, so you have to treat the mom first.
So you're okay with our treatments of Versed and Ativan and all that?
Everything, yep, go for it. And if that's what we're doing, like the ER, if they're still seizing, or if you broke it with Ativan and then they seize again, they get the next level. So all regular medications,
But give mag.
but give MAC,
Yeah.
yeah.
Yeah, and this is another example. So 5 grams. So in the hospital, I'd give that over 5 hours, and in this setting, you're giving it over 15 to 30 minutes. So it's a very different world as far as that goes. Cardiac arrest. Jalee, I'll let you take this one too.
Yeah. The big thing specifically, so you guys always do a great job of calling ahead, but essentially if a mom is pregnant and getting any sort of chest compressions, we need to do an immediate C-section. It doesn't matter if they're like 22 weeks and that baby isn't viable. At the very end of the day, we're trying to resuscitate mom, and the uterus takes like half of the blood flow, and so we essentially do not care about baby, any medications you need to give. We're just trying to like resuscitate the mother at this time. Which can be really tricky when, you know, the patient's unresponsive, obviously, and then family members may not know, be like, they're pregnant, but how far along are you? Do you guys have any idea to, like, guess how far along someone is? pregnancy-wise?
That fundal measurement, right?
The fundal measurement, yep. So when would you like care for CPR and that sort of stuff? It doesn't have it up there. Yeah, 20 weeks. And so essentially, if you have an unresponsive patient, you're starting chest compressions, and you notice that they have a big belly, you just feel and look like, where is their belly button, and do you feel a big ball at the level of the belly button? Treat them like they're 20 weeks pregnant. Treat them like you need to get that uterus off of the IVC and the aorta. And so it's essentially routine CPR, but it's really nice to have an extra pair of hands in there. You can do the tilt, the wedge, where you get the mom, it's technically left side, but like just tip the mom, so then they're not laying, so the uterus isn't flat on all of the big vessels. But then you're doing chest compressions at like this angle, and that's kind of weird. It's better if you can have someone actually like grab the uterus and pull it to the side. And literally you like,
And
you
it's,
dig
I
in
mean,
there
it's,
and you pull the uterus
it's a
to the
forceful,
side.
I have a pregnant lady right here.
Yeah. Yeah.
So, but essentially, yeah, you're gonna grab this baby and you're gonna,
Pull, you can go
oh
way
yeah,
deeper.
and you're gonna pull.
way deeper
I know, I'm
than
not
that.
gonna do it to you. But I'm gonna, so you straight arms and then with all of my body weight, pull back and pull that baby as much as you possibly can off that IVC and aorta.
So that's, if you have a spare person to do that, while someone else is doing chest compressions. And then the other thing that you just keep in mind, which probably won't be you guys, but if you're doing IV access, it has to be above the diaphragm. In the ER and the ICU, they love to do femoral lines during chest compressions, but then all of those medications are just going straight to the uterus and not getting to mom at all.
So what about like IOs? And
Yeah.
That has to be
Above the diaphragm.
okay for even IOs.
So, and then get the hospital a heads up, because I will meet you in the ED with a plastic scalpel if I have to, and do a C-section in the ER.
So if this happened in the hospital setting, how fast do you need to get that baby out?
You don't roll 4 minutes. 4 minutes from starting chest compressions to delivery of baby. So you don't even like roll to an OR, you don't get your stuff, the patient's not bleeding because there's no perfusion, and so it's literally a plastic scalpel in an ER room.
So 4 minutes is your time. So, and if you guys are out in the field, obviously that is a shitty situation.
So if we're out in the field, just kind of, it sounds like this would probably change our thought process on staying and playing. Like if we have a pregnant lady that's in
Yeah.
full arrest, just go.
My preference is, I would
Okay.
like you to do chest compressions in the.
Well, yeah, obviously doing chest compressions, but like
But don't
our
try to
normal
resuscitate.
adult full arrest, we're gonna sit there
Yeah.
and we're gonna
no.
work them till either they're dead or we get them back and we go.
No, you
So
want to
with
get
this
into the
one,
hospital.
My preference.
full arrest, let's just go.
Go to the hospital. Yeah, that's exactly right.
What's the longest that you can, I mean, obviously a lot of our transport is going to be the 4 minutes.
Yeah. From when they roll in general, like 20 to 30 minutes of mom not being oxygenated is then when you kind of like lose baby at that point. So we'll, depend on what sort of, there was a case last year at Davis of a mom that was down in the field, got chest compressions. You guys were semi-able to resuscitate her. She got into the hospital, they got her stabilized, and then coded again, and it's, more than 20 minutes, there's loss of brain tissue for everyone.
Yeah, this is a scenario that nobody wants to encounter, and honestly, you do everything you can do, but it's not a hopeful situation by any means. Okay, let's see, I think we talked about all this already. And then stillbirth and fetal demise. Treat the mother first, supportive and respectful care, do not attempt resuscitation of a clearly stillborn fetus. Management, carefully collect all products of conception, transport the mother to the hospital, coordinate for their actions with medical control if needed. I don't, me personally, like I said earlier, I don't love this of a clearly stillborn fetus, just because I've had lots of floppy babies that I thought that baby's dead, and it wasn't. So I don't, obviously.
And I think it was actually interesting reading through it and then bringing up law enforcement too, because you can hopefully kind of tell if the baby was recently delivered or not, like if there's a ton of blood and the mom's laying there, or if the cord's still attached or that sort of stuff, If you get to a situation where you come in and they're like, oh, I just delivered this baby 10 minutes ago and it's cold and gray and there's not a lot of bleeding, that sort of stuff, then that makes you think that there's something more suspicious going on, that you would want to get law enforcement involved versus like an active delivery scene is going to be crazy.
All right. Questions with any of this? Okay. I want to end on a high note. You guys know this guy? Will you click it for me?
Alright, I can see the head. A couple more big pushes and the baby's gonna come out, alright? Oh, hey, you must be the boyfriend. Yeah. I saw the truck's outside. You good? Is she okay? Dude, she's doing great, man. The baby is almost here. Oh, so good. Oh, yeah. It's a boy! Hey, listen, bro. I know this feels completely overwhelming right now, but don't worry, man. You're gonna be an awesome dad. No, it's not bad. I just got back from college and I'm gone for a year. Okay, who's ready to go to the hospital?
All right, guys, that's it. Thank you for your attention. Thanks for participating. You guys have been awesome. Any last minute questions? You want to talk about cases that you've had that you want to discuss with Jalee? This is the time to pick her brain. Any other questions you might have?
Total left field question. Is it appropriate? It's appropriate.
I take the inappropriate ones.
So, in the field C-section, how many like documented cases of that happening? Probably not very often.
Yeah, don't do it just because there's too much of a risk for
Well,
like bowel injury or that sort of stuff. Yeah.
It'd have to be a really weird scenario.
Yeah, there's too much bowel that you can cut.
Oh, this is
so-
like an Edward
so-
and Bella thing, isn't it? Yeah. Remember that? The girls know. Yeah, it's like this is. Is that-
Wow, that was good. Wow. I was like, I didn't think about that one. That was good.
So don't do it.
Wow.
Save it
That's
for me.
really good.
They do it on TV all the time.
I had one that, 22 weeks, came out, looked like it was gonna be still, did a little bit of, stimulation, breathing on its own, heart rate, took it to the hospital and then they allowed it to still expire without doing any aggressive, I know 22 weeks is right there, but then I just saw in the news just recently about another 22 week that they did do aggressive, what?
24 is technically like viability where you, like hospitals and everyone have to attempt like legal resuscitation. You can't just let the baby pass once they're 24 weeks.
In the state of Utah.
Sure. And fair enough. But for like resuscitation efforts, 22, we've had some successful. I've delivered a 22-weeker that's a couple years ago that's still alive and kicking today. There's, I'm sure in some states, maybe even they've kept some 21-weekers alive with some really aggressive stimulation. So try to do what you can when it comes into that nuance between that like 21 to 24 when like maybe we could save the baby but maybe not. It comes down to a deeper discussion with the parents of if they want to resuscitate and go from there. So for your purposes, do what you can. There's not a whole lot that you can do for a 22-weeker. The big thing is like lung development. They're not going to have lungs. And so if they're able to function enough to breathe, to get them there, great. But most of the time, they won't even be able to get past like the 5-minute mark just with oxygenation of lung development. Unless you tube them, which I would not recommend trying to intubate a 22-weeker in the field.
And I guess we have a question online for one of our Zoomers.
Hi, can you please speak to the JADA suction system for us for postpartum hemorrhage? We recently had a transfer with one of these inserted, and it was the first time we had heard about these or seen these. Can you speak to that a little bit?
Oh yeah, IHC's probably, the latent IHC's probably transferred about 10 people this last month from Layton to McCady with Jada's in place. So it's definitely something you'll see. So essentially it is a balloon that is inside the uterus that has a little bit of suction to it. And so it's sucking the uterus onto the balloon. And so it's kind of doing that fundal massage, doing that contracting. It's trying to keep the uterus small so then it doesn't fill up with blood. And so you can, I don't know your guys' suction. Do you guys have suction? Well, you have some suction. I don't know if you have a separate. It needs like its own suction. If they were able to keep it on suction or to keep it off of suction just for that transport time. But essentially they're pretty sturdy. You can't really like pull them out of place at all. Just in general, as you're transporting a patient between hospitals for postpartum hemorrhages and resuscitation and things like that, you want to keep an eye on the bleeding. But you shouldn't really have to mess with it. It's just trying to keep the uterus shrunk down.
Thank you.
So this is after baby's delivered, then you put Jada
Like
up
they've
there.
had a ton of hemorrhages that they can't control at Layton recently, that they punted up to McCady for blood products and things like that, and so they have Jada's in place.
And so the Jada sucks the uterus onto the balloon, and so it kind of causes that.
It's the new
That's
the
kinda cool.
Bakri.
Yeah.
It used to be the Bakri, but
So yeah,
with
but the
suction.
Bakri would push outwards.
Yeah, so.
And the Jada sucks inwards. That's interesting.
So there's other balloons. They might have other like sort of uterine packing, but the Jada's the one that we use now.
So is that something where we're gonna need to bring in our like portable suction to transfer that over to them and then have that
I
on?
suspect.
Why can't they just put in a bunch of Foley's?
They could. It's cheaper.
Yeah, yeah. So I mean, essentially you're trying to tamponade all that bleeding, right? So I was gonna say one of the things that I've seen the most is you just stick a bunch of Foley's up there and load them up with as much fluid as you can, and that puts the pressure onto the uterus internally, and it does the exact same thing essentially than these fancy schmancy devices do. But okay.
This might be an obvious answer that I just don't know. With cardiac arrest with a pregnant lady, can you do an auto pulse or is it always going to be manual CPR?
Preterm labor, we have, I think the protocol says mag, albuterol, and
A liter fluid bolus.
there you go.
Yeah, a lot of fluid.
I-
For the imminent, are you talking about the imminent delivery rocks?
Well, yeah, just,
Yeah, the imminent preterm delivery.
Yeah, that's a great, and we didn't talk about this.
Yeah,
Jalee and I
it's-
had some interesting discussion about it last
It's
night.
kind of hard because it's like how, especially for preterm labor, like unless the baby's coming out, like how do you really know that they're in preterm labor? Because that's a lot more of the situation where they're like the baby's coming out and they're contracting, but their cervix is 2 to 3 centimeters. And so
It's hard to know.
Yeah, my preference is it's a lot harder to know, like and medication, like if even in the hospital, like if someone's in preterm labor, we cannot stop that. We can give all the medication, we can give all the magnesium, we can give all of these things, and the baby's still gonna deliver. You're just trying to kind of prep the baby for delivery, but the 10 minutes of your prep versus the 24 hours or 48 hours that we're trying to get from the baby is not gonna make a difference. So I lean towards just transport the patient, but I know your protocol has things.
Yeah, we were
That's
talking
my
about the
vote.
albuterol because Jalee never heard of that. I had never heard of that either, giving the albuterol, and essentially, because it's a beta agonist, it does the same thing as terbutaline,
Yeah, that's what we give
which
in
is what they use in the hospital. And even that, I think there's some evidence that terbutaline doesn't do anything. So we thought that was that. We learned something there. I have no idea, but okay.
Well, if we get a pregnancy call in the next 10 minutes.
I'd love that.
That's how it always happens.
I'm gonna,
You get a call.
yeah, I'm gonna fight Jalee for it for sure.
I had one last question. I feel like I've gone on like 2 or 3 miscarriages, either planned, like they know, or early, spontaneous. And if the patient wants to go to the hospital, for sure, right, we're doing that. But sometimes it's more they're just kind of confused, trying to process it. Are there specific things that you guys would see that would be like, yeah, like we probably need to go? Because usually their vitals are stable. We're just trying to provide some comfort to them. But are there any things or in the ER that you guys are like, oh yeah, like Cause usually it's either early, it's spontaneous, or it's already planned, so it's kind of like.
Yep.
this is a
Our
date.
kind of rule for like when we need to medically intervene, is essentially if they're obviously hemodynamically unstable, if their blood pressures have tachycardic, anything like that, then bring them in. And then our like normal outpatient rule is if they're going through 2 pads an hour, that's kind of the amount of bleeding, for kind of 2 hours straight, then that's enough of an active hemorrhage, then we need to intervene in the hospital and do an ultrasound and check what their hemoglobin is or do surgery for any retained products. And so that's kind of the level that we have to do something. I don't know your guys' protocol as far as if, you know, you can ask the patient about like, well, how much has your bleeding been, or kind of see how much they're bleeding. There's obviously gonna be a clot with the actual products, like if they have it or if they flushed it down the toilet, that you can potentially look like a decent amount of bleeding. So that's a little bit of kind of the nuance if the patient can be like, no, if they're not actively, if they don't wanna go, if they're not actively bleeding, if their vitals are stable, and then, well, watch it for an hour, but if it stays, then we want them to come in, so.
But
I don't know if
that's,
that helps.
that's
hard
your
for you
trigger
guys.
point?
That's
For you
our
guys
trigger.
is two pads per hour for 2 or more hours?
Yeah, then they
Okay.
need to be, then that's too much, that physiologically they
So
can't
that-
handle it.
It's good to know your guys' trigger points, because like we base a lot of our stuff, you know, off of what the hospital would do.
Because if it's just like a period, they'll come in on ultrasound, your hemoglobin's fine, your vitals are stable, you're going home.
Goes back to a lot of patients, and you guys know, you guys see this, but like they'll be like, oh my gosh, there was this huge massive clot, and you see it, and it's like this tiny little baby thing,
And
you
I had a
know.
phone call last night for half of a baseball size. I'm like, okay. Cool.
Yeah. Or yeah, there's just blood everywhere, and you see it, and you're like, this is like barely 100 milliliters of blood, you know, and so it can be very deceiving and very worrisome to patients. And so I think it's good to like have this clear cut, like if you soak 2 pads in an hour for more than 2 hours, then give us a call, and you can just tell them that. Great
Another-
question.
Another online one. So you were talking about the Ativan Versed. So do Ativan Versed first and then MAG, or the other way around? MAG first and then Ativan Versed?
All at the
All
same
at
time.
once.
All at once.
Just give it all.
Copy.
Yeah.
We'll do the MAG.
Well, but
and
the
then,
mag, so
and
the,
then
so the mag
whatever-
takes 15 to 30 minutes,
No.
is what they're.
Well, you push it over 15 to 30 minutes, but if the patient's still actively seizing, you're not gonna let them seize for 15 minutes before doing your next med. So you start the magnesium, and if it's more than 60 seconds, you know, go for your Ativan. And then I don't know your time for your normal, I don't do the seizures, anesthesia does them, or the ER does them for me, so I don't do the seizure meds, but Ativan and then whatever your next, and then your phenobarb or whatever it is, whatever your normal time on the
So
pill
are you
is.
saying, so like give the mag, and then if they're still seizing, just push the mag, like don't do the 15 to 30 minutes?
No, I mean, you can still let it run over the, like, you can still do the
I
15,
think
but I
it's
wouldn't
probably
not
the way
give
we
medications.
operate, the way this is
Yeah.
probably gonna go down, we'll either establish an IV super quick, give the rescue med, the Ativan,
Uh-huh.
whatever,
Uh-huh.
and then
Then
set up, as we're setting up the mag
Get the
to
mag
deliver
going.
the mag.
Yeah.
Either that or just straight to IM with the
Yeah.
benzo,
Mhm.
and then work on our IV once they've stopped
Do you
seizing.
know
Yeah,
if they're
that's fine.
compatible?
They
They're
are,
gonna be a lot easier to work with when they're done seizing.
yeah,
and stop seizure.
but you're not gonna like let them seize for 15 minutes
Yeah.
as the max going.
As the mag's going in. Okay. All right, guys. Anything
Thank you,
else?
guys.
Yeah.
Thank you.
Thank you.